Good morning. So we're going to cover Section M, Skin Conditions, Pressure Ulcer / Injury. And as you know, we start with our acronym list, so we can look through that. The objectives for today's session is we're going to be able to state the intent of Section M, the skin conditions, and we're going to be able to describe the cross-setting pressure ulcer injury quality measure, so we'll understand that. And most importantly, we're going to be able to apply the coding instructions to accurately code the practice scenarios and the case studies, and I think that's where we get the greatest learning. So the intent. The intent here is to document the presence or the appearance or the change in status of a pressure ulcer or injury based on a complete and ongoing assessment of the patient's skin, guided by your clinical standards. And it is to promote effective pressure ulcer injury prevention and skin management programs for all patients. And so we define the pressure ulcer as a localized, or pressure ulcer injury as a localized injury to the skin and or underlying tissue, usually over a bony prominence, as a result of intense and or prolonged pressure or pressure in combination with shear. The pressure ulcer injury can present as intact skin or as an open ulcer, and certainly it may be painful. So I think the key word that you're going to take away from this, and I know this is silly, but people struggle when they're trying to code. If you're coding it as a pressure ulcer, it needs one thing as part of it, the process here, and that's pressure. So a lot of people struggle with moisture-associated dermatitis and a variety of other things. If there happens to be pressure related to the injury, then we can code it under pressure injuries. If there's no pressure related to it, then it's not a pressure injury and wouldn't be coded here. So changes in skin integrity, post-acute care, and the pressure ulcer. So here we are. For this measure, an ulcer or injury is considered new or worsened at discharge if the discharge assessment shows a stage 2 through 4 or unstageable pressure ulcer injury that was not present on admission at the same stage. So this is an important definition. So anyone who is going to be encoding the IRF-PAI needs to understand this definition. So you have to make sure that it's considered new if it wasn't there on admission, and or if it was there and is either a worse stage or an increased stage and or unstageable at discharge. So going through the numerator and the denominator here. So the numerator for this particular measure includes stays in the denominator in which the discharge assessment indicates one or more new or worsened stage 2 through 4 pressure ulcers or an unstageable pressure ulcer or injury as compared to the admission, which is what I just said in the previous slide. And then the denominator for this particular measure is patient stays having two things, both an admission and a discharge assessment, planned or unplanned, except for those that meet any exclusion criteria. And we're going to go through the exclusion criteria next. So a patient stay is excluded if data on the new or worsened stage 2, 3, or 4 unstageable pressure ulcer injury, including deep tissue injury, are missing on the discharge assessment. So that makes sense, right? Because I just said we need to have an admission and a discharge. If you're missing the information on the discharge, we can't match those. So we can't have, so they get excluded from the file. Or the patient died during the stay. So they're pretty simple. Those are the exclusionary criteria. Otherwise, they're included in the denominator. So the time frame for this window. The measure will be calculated quarterly using a rolling 12 months of data. For public reporting, the QM score reported for each quarter is calculated using the rolling 12 months of data. All patient stays during the 12-month, except for those that meet the exclusion criteria, are included in the denominator and are eligible for inclusion in the numerator. For patients with multiple stays during a 12-month time frame, each stay is eligible for inclusion in the measure. So if they had multiple stays meeting the criteria that I talked about earlier, then one patient could be included multiple times. Some of the things to take into consideration are some risk adjustments that are done for this measure. And the admission assessment items used to risk adjust this quality measure include functional mobility admission performance, specifically looking at question GG 0170C, lying to sitting on the side of the bed. So we think about that. It's a mobility issue, right? So if someone has difficulty from getting from a lying to a sitting position, those tend to be more dependent people. Bowel continence. H0400 bowel continence. So if someone tends to have incontinence of the bowel, it puts them at higher risk for pressure ulcers or injuries. Peripheral vascular disease, PVD, or peripheral arterial disease, PAD, or diabetes. So I0900 for PVD or PAD, and or I2900 for diabetes. And if you're a clinician, those make sense to you. These are patients that are at higher risk. And then the last one is a low body mass index based on height and weight. And so a couple of times there were some questions that were asked about calculating the BMI, and how it's done on the back end is using height and weight. So 25A and 20 for height and weight. So that's what's going to calculate our low body mass index. Now, clinically, you might want to consider someone, for this risk adjustment, we're just looking at low BMI, but you might want to think about someone who has a very high BMI also. It's not going to be a risk adjuster here, but from a clinical point of view, when you're trying to manage skin, maybe something that you want to take into consideration. So coding guidance and practice coding scenarios. Using the term, this pressure ulcer terminology, CMS is aware of the array of terms used to describe alteration in skin integrity due to pressure, including pressure ulcers, pressure injuries, pressure sores, decubitus ulcers, and bed sores. So any number of those names can encompass what we're talking about today. It is acceptable to code pressure-related skin conditions in Section M if different terminology is recorded in a clinical record, if the primary cause of the skin alteration is related to pressure. All right, so people use a variety of terms, but it's, so what we're saying here is as long as there's pressure related. Again, I just want to talk about some of the common questions that we get related to these particular items. So when considering wounds with mixed etiology, such as moisture-associated skin damage, it's extremely important to identify the primary cause. So you have to determine if we have someone who has moisture-associated damage, skin damage, do they also have pressure involved with that, and do we actually have then a pressure injury? So CMS adheres to the following guidelines. So these are important because the terminology, and this is around educating your staff, making sure everyone has a shared mental model on this. A stage 1 pressure injury and DTIs are termed pressure injuries because they are usually closed wounds. So the damage is below the skin, but the skin is usually intact. Stage 2, 3, and 4 pressure ulcers or unstageable ulcers due to Slough and or Eschar are termed pressure ulcers because they are usually open wounds, so the epithelium is gone. Unstageable ulcer injuries due to non-removable dressings or devices are termed pressure ulcers or injuries because they may be open or closed wounds. And the key for that one, when we get to it, is talking about when you have a non-removable dressing, the key here is you have to know that there's an injury underneath it. A lot of people ask a lot of questions about it. Well, there could be, I don't know, there might be, how should I code that? If you know from the previous setting that you actually have an injury or an ulcer underneath that non-removable dressing or device or cast or whatever, that's when you're going to code it here. Okay, so current number and unhealed pressure ulcers or injuries at each stage. So at M0300A1 through G1, it identifies the number of unhealed pressure ulcers or injuries at each one of the stages, and it establishes the patient's baseline assessment. So that's your assessment, your admission assessment. And there's really 2 points for this measure, right? There's what happens, what you see on admission, and then what's present at discharge. It's 2 points in time that we're looking at. So M0300 A1 through G1 identifies the number of unhealed pressure ulcers or injuries at each stage. and M0300B2 through G2 at the time of discharge identifies if the unhealed pressure ulcers or injury in M0300B1 to G1 were present on admission, or if the pressure ulcers or injury were acquired and or worsened during the stay. And again, that's that second point in time, and that's the discharge assessment. So let's talk about some of the medical documentation. You want to use documentation from the previous setting to inform about the original stage of the pressure ulcer or injury, and this is critically important. And you want to review the history of each pressure ulcer or injury in the patient's medical record. It could be through an assessment prior to them coming in to be admitted into your facility. It could be in nursing notes. It could be in progress notes. It could be in a variety of ways. You could have been told this as part of your warm handoff. So you want to make sure that you understand that, because if you have an injury coming in, and this is not uncommon, where it was coded at its greatest stage as a stage 4 pressure ulcer, and by the time they come to you, they might have spent an extended period of time in another setting. And what you visualize when they come in might be something that would be akin to maybe a stage 3. So would you code that as a stage 3 or a stage 4? If you know that it's a stage 4, we don't reverse stage, right? It always will be a stage 4, even though what you're visualizing looks like a stage 3, because you know from the previous setting that it was a stage 4, that was its worst, and it will stay a stage 4 until it is closed and healed. So that's an important piece to make sure that you're communicating and educating with your staff. Sure. So I asked to repeat that again. So an important point to take away from knowing what the greatest stage a pressure ulcer was. So for example, if you had a patient who was admitted to your organization, your facility, and previously they had been in maybe an extended stay in acute care, and their deepest, let's say they had a injury on their coccyx and it was staged as a stage 4. By the time they get to you, they had great care, they got to you, what you're visualizing looks like a stage 3 to you, to your eye, okay, by your assessment. But what you want to do is code that as a stage 4, right? Because we don't reverse stage, because you know it was a stage 4 from the previous setting. So it will remain a stage 4 until the point that it heals or closes. So it's an important piece of information for you to have. Okay, so steps for completing M0300A through G. Determine the deepest anatomical stage, which we just talked about, and identify unstageable pressure ulcers or injuries. So for the discharge assessment, determine the number of pressure ulcers or injuries that were present upon admission. So that's the first step, what was present upon admission. And then there's pretty detailed instructions in the IRF-PAI manual, so we encourage you to go out to the manual and look at that. So with the discharge assessment, you want to make sure that you want to know what's present upon admission, but you also want to determine what's there now. So at discharge, I think it's almost easier to kind of look at the patient and say, what pressure ulcers does the patient have now upon discharge? Then I want to say, okay, of what I see today, what was present upon admission? So I'll go back to my documentation and understand what was present upon admission. And then we're going to go through a variety of scenarios as ulcers change on how we code those. So these are just screenshots looking at your assessment here, M0300. And it describes each one of these wounds. I think one of the greatest things that you can do for your staff or anyone who's going to be doing these skin assessments is for them to really understand the definitions that are being used here. And to be able to describe in detail what they're seeing into the medical record. What we have found sometimes is that a staff member, did a skin assessment and they described something as, they staged it as a 2. This is a very classic one. They staged it as a stage 2 pressure ulcer. But they described this wound, they measured it, and they describe it as having this yellow slough on it. And we all know as clinicians, or we should know, a stage 2 pressure ulcer can't have slough. It's automatically a stage 3. So in that scenario, it's an opportunity to educate that nurse that what she or he in fact was seeing was a stage 3, and you have now a good description that really, it didn't deteriorate, it was a 3. I mean, on that initial skin assessment. So you would have to just correct your documentation on that. So this is a screenshot, here we go. And then in the coding here, we talked about these. So M0300A1 through G1 are completed upon admission and at discharge. And you want to enter the number of pressure ulcers or injury that are currently present, and enter 0 if no pressure ulcers or injury are present in that item. So here we have the current number of unhealed pressure ulcers and injuries at each stage, but this is the discharge assessment. So we just looked at the admission assessment, now we have the discharge assessment. And what you'll notice here, this is the screenshot, we're going to go on to kind of explain these. So this says all the unstageables here. Is here you have M0300B2 through G2, and they're completed at discharge only. And you want to enter the number of these pressure ulcers or injury that were present upon admission. And you're going to enter 0 if there were none. I'm just going to go back a slide here. I think it's worth a moment of kind of explaining this. So if you say, let's look at the stage 3, and it says the number of stage 3 pressure ulcers that you have. So what it's asking you right here is, today at discharge, how many stage 3 pressure ulcers do I have? So let's say I have 1. Okay, I have 1. Then the next question it's saying to you is, okay, of that 1 stage 3 pressure ulcers that you have today at discharge, how was it present upon admission? Did you have stage 3 pressure ulcer on admission? And if you don't, you answer 0. All right, and we're going to go through a bunch of scenarios. I think this is where probably the area that people struggle the most with. Okay. So here we have the present upon admission items. They're coded at discharge and address whether the pressure ulcer or injury observed at discharge were present upon admission or acquired or worsened during the stay. That's really the crux of what we're looking for in this particular item. So a pressure ulcer or injury reported at discharge and coded as not present upon admission on the discharge assessment would be interpreted as new or worsened. Wasn't there, or is at a greater stage, or is covered with Slough or Eschar, is considered new or worsened. A pressure ulcer or injury reported at discharge and coded as present on admission on the discharge assessment would not be considered new or worsened. So if I had a healing stage 4 on admission, right, let's talk about that scenario, and now I'm getting to discharge, it's still healing, it's not covered with Slough or Eschar, it's still healing, it's still a stage 4, that would be considered present upon admission. It hasn't gotten worse, it's still there, it's still going through its healing process. So if a patient, so let's talk about program interruptions. So if a patient is transferred from the inpatient rehab facility to an acute care hospital and returns within 3 days, including the day of transfer, the transfer is considered a program interruption and is not considered a new admission. I think you all know that, right? You live with this every day. Therefore, any new pressure ulcers or injury formation or increase in a numerical staging that occurs during that program interruption should not be coded as present upon admission. So if someone goes out with a stage 2 and they're out for 48 hours and whatnot, and they come back, so it's considered meet all the criteria for program interruption. Now you do your initial skin assessment, and that same wound that was a stage 2 is now a stage 3. On discharge, you can't say that that stage 3 was present upon admission because it happened during that program interruption. You basically own it. Okay? Okay, so we're going to go through a practice scenario here. We're going to use Slido, and I think you have in your packets these scenarios, so if you want to look at them, if everyone get their Slidos and everyone who's live streaming here, and we'll prepare to answer some of these questions. So first coding scenario, a patient is admitted to the IRF with a stage 2 pressure ulcer on the left hip. The patient is transported to an acute care hospital and returns to the IRF within 2 days. So this is considered a program interruption. Upon return to the IRF setting, the left hip pressure ulcer is full thickness ulcer, assessed to be a stage 3. The patient is discharged to home with the stage 3 pressure ulcer. So now we have to code this. So let's review this again. They came into the IRF with a stage 2 on the left hip. They had a program interruption when they came back to you within that 2 days. They had a full thickness, so now it's a stage 3. And then they're discharged home with a stage 3. So let's go through this question. How would you code M0300 on the admission assessment? Would you code it as M0300 B1, stage 2, C1 as a stage 3, 300D1 as a stage 4, or 300G1 as unstageable? So this is the admission assessment. That's what we're asking about, the admission assessment here. Give just a moment. We're getting a lot of people answering. Okay. So let's see what the answer was here for this question. And in fact, the majority of the people got this correct. It was a stage 2. I think some people clicked stage 3, but that was, I think they were thinking the discharge assessment. So on admission, this patient came in, had a stage 2. Now let's ask that same scenario. Now we're to the discharge assessment. How would you code M0300 on the discharge assessment? Would you code it as 300B1 as a stage 2, 300C1 as a stage 3, M0300D1 as a stage 4, and or unstageable? Okay, we got a good portion of people. Most people think a stage 3. And let's see what the answer is. So how would you code this on discharge? Actually a stage 3, right? Because they had that program interruption, it's now a stage 3. So great. Now the big question is the number of these stage 3 pressure ulcers that were present upon admission. So did we have M0300C2? Would it be a 0? Would M0300C2 be a 1? M0300C2 be a 2, or would we skip it? So we're looking at those stage 3 pressure ulcers that were present upon admission. All right, we've got a good majority of the people have answered this, so let's see what the answer is. And it was 0, and that makes sense, right? Because we just talked about that. They came in with a stage 2, they had the program interruption, it advanced to a stage 3. It continued to stay a stage 3 on discharge. So we had one stage 3 on discharge for this particular scenario. And even though they had a pressure ulcer, it was at a lower stage, a stage 2. It's now a stage 3. It would not be considered present upon admission. I know this is like splitting hairs, but believe it or not, these are the scenarios that people struggle with, this type of scenario. So good opportunities for educating your staff. So this is how you would actually encode it on the IRF-PAI. So you show the admission assessment with the 1 for the stage 2, and then the discharge assessment. We say we have 1 stage 3, and of those stage 3s, 0 were present upon admission. And we just talked through that, and we talked about being transferred and how they came back, and then that's not considered a new admission. So it was just an interruption. And so now we had the stage 3. All right. Let's talk about unstageable pressure ulcers. The visual inspection of the wound bed is necessary for accurate staging. I think we all know that if you're a clinician. Pressure ulcers that have eschar or slough tissue present, such as the anatomical depth or soft tissue damage, cannot be visually inspected or palpated in the wound, should be classified as unstageable. So if you can't see what's going on underneath that slough and eschar, then you need to code it as unstageable. If the wound bed is only partially covered by eschar or slough, and the extent of soft tissue damage can be visualized, inspected, or palpated, the ulcer should be numerically staged and should not be coded as unstageable. So what kind of scenarios could we have that? In that scenario, we could be looking at a wound. It could have only a small area that doesn't have eschar or slough over it, but we see bone or we see tendon, and we can palpate that. It's automatically stage 4. So we don't need to clean the rest of it off. It's at least the part that we're looking at, you clearly can see that. If there's any question about what's going on underneath it, then you have to code it as unstageable. So now let's look at another practice coding scenario. So a patient is admitted to the IRF with a stage 4 pressure ulcer on her left hip. When the pressure ulcer is reassessed at discharge, it is entirely covered with eschar and the wound bed cannot be assessed. The patient is discharged with an unstageable pressure ulcer due to slough and eschar. So how would you code M0300 on admission, on the admission assessment for this patient? Would you code M0300C1 as a stage 3, 300D1 as a stage 4, 300F1 as unstageable due to slough or eschar, or just unstageable deep tissue injury? So we have a majority of the people responding, and it looks like most people think it's B, a stage 4. So let's see what the answer is. So in fact, you're correct. It's a stage 4. At this point, some people had coded that unstageable due to slough and eschar, but that was information that you found out not at admission, but at discharge. But now let's look at that discharge assessment. How would you code M0300 on discharge assessment? So would it be M0300C1, stage 3? Would it be a stage 4? Or would it be M0300F1 unstageable due to slough or eschar? Or would it just be M300G1 unstageable due to deep tissue injury? Okay, we have the majority of the people who have answered, so let's see what the answer is. And in fact, you would code here M0300F1 as unstageable slough or eschar. Now, there were not a huge majority, but there was enough people who answered that as a stage 4. And there's people who have said to me, well, Ann, if it's a stage 4, it's a stage 4. It can't get any, we don't have stage 5, 6, 7, and 8, right? So stage 4 is the worst it can be. And you said it stays a stage 4 until it's healed. In this particular situation, again, this is a nuance of how to code this. Even if it's stage 4, if it's now completely covered with slough or eschar, it is considered worsened. New, well, it wouldn't be new, but worsened in this particular situation. So that's a training opportunity for anyone who's going to be encoding the IRF-PAI. So if you make sure that they understand in this particular situation, you would code it as unstageable, and in fact, it would be considered as part of worsening. Was this unstageable pressure ulcer due to slough or eschar present on admission? So if we can just answer that, yes or no, or skip. Okay, I'll just give it a moment. Okay, let's go to the answer and see what we have. So was this unstageable pressure ulcer due to slough or eschar present upon admission? And we say no, but there was in fact 25 or 30 people who said yes. So again, this is a point of clarity. What we're saying is what we see now in discharge is an ulcer that has slough and eschar, and in fact, it wasn't that way on admission. So in this scenario, it would be coded as a 0 or no. And then if you were looking at the coding, here we have it. So we don't have any stage 2 pressure ulcers, so we would code those as 0, and then we would skip 300B2 because that is specifically asking about, if you have a 0 on the discharge assessment in the prior question, the next answer will be a skip because it's asking of those ulcers that you have at the discharge assessment, how many were present upon admission. If you have 0, you can't say how many were present upon admission, okay? So you'll see that same pattern for their 300B1 and B2, 300C1 and C2. Now we get into M0300D1, number of stage 4 pressure ulcers, which we have there is coded as 1. On the discharge assessment, we don't have any of those, right? Because now it's covered with Slough and Eschar, so we'd say 0, and we're going to skip. And then it goes on to the next bit here, and it says the number of unstageable pressure ulcers due to non-removable dressing. Well, we didn't have any of those, so we go 0, 0, and a skip. Then M0300F1, number of unstageable pressure ulcers due to coverage of the wound bed by Slough or Eschar. Well, we didn't have that on admission, but we do have it at discharge, so we're going to code that as 1. And then the following question says, of those ulcers that are covered with that, was that present upon admission? And you're saying no. And this just basically goes through the explanation of why we did the skip patterns, in which I just talked you through. All right. So let's talk about non-removable dressings and devices. This is another area that gets people a little uneasy, and there's some questions around it. So non-removable dressings or devices refer to a dressing or device that may not be removed from the patient per a physician order. So these could be a primary surgical dressing, it could be a cast, it could be a splint of some sort. Often they can come with something, and the orders are don't remove it for a period of time. So non-removable dressings or devices include I guess I've taught this too much. I'm ahead of myself here. Primary surgical dressings that cannot be removed, or orthopedic devices, and or casts. So those are the most common ones that we'll see. So a couple of key points here. You need to have a known pressure ulcer or injury covered by a non-removable dressing or device. It should be coded as unstageable. Known pressure ulcer or injury. So that, people struggle with that. They're like, oh, well, I have this cast, and I don't know what's underneath there. Okay, that's fair. But what we're talking about for this coding, this part of the scenario here is saying, we know from the previous setting or from, it was documented that this dressing, this primary dressing, this cast, this device or whatever, we know there's something underneath it. And they may even tell you what stage it is. But then you turn around and you're like, well, I can't take it off, so I can't visualize it. So you need to say, there's something there, but I can't code it yet. So, but only if you have a known ulcer underneath it. So that's probably the biggest teaching point for you to take away here. So when there's documentation available indicating that a pressure ulcer injury exists under the non-removable dressing or device, you want to review the medical record for documentation of the pressure ulcer injury covered by that device or dressing, and do not assume that there is a pressure ulcer injury that is covered by a non-removable dressing or device unless you know about it. So let's look at a practice scenario here for scenario 3. So a patient is admitted to the IRF with documentation in the medical record of a sacral pressure ulcer or injury. The ulcer or injury is covered with a non-removable dressing. Therefore, the pressure ulcer or injury is unstageable. On day 4 of the IRF stay, the dressing is removed by the physician and assessment reveals a stage 3 pressure ulcer. On day 9 of the IRF stay, the pressure ulcer is covered with Eschar and is assessed as unstageable. The Eschar covered ulcer is unchanged at the time of discharge. So this one's a little more complex. All right, so they came in with a dressing that was non-removable. Day 4, we take the dressing off. It's staged as a stage 3. It progresses to have Eschar on top of it, and then at discharge it still has Eschar. So let's think about that scenario. How would you code M0300 on admission assessment? So this is again the admission assessment. Would you code a stage 3 in 300C1 or 300E1 unstageable due to a non-removable dressing or device? Or unstageable due to Slough and Eschar, or unstageable due to DTI. Okay. We've got a good response, so let's see what the answer is here. So in fact, it would be unstageable due to non-removable dressing or device. I saw some people code it as a 3. Well, you found out it was a 3, but that was on day 4. So it was what you were looking at was unstageable due to a non-removable dressing or device. And then a couple of people, I think 7, coded as having Eschar, but again, that didn't happen until day 9. So you need to just make sure you understand what you're looking at here. How would you code M0300 on the discharge assessment for this particular patient? Would you code 300C1 as a stage 3? 300E1 as unstageable due to the non-removable dressing or device? Would you code it as 300F1 unstageable due to Slough or Eschar? Or would it just be M0300G1 unstageable due to deep tissue injury? Okay, and let's see what the answer is. And in fact, it's unstageable due to Slough or Eschar, and that is the correct answer, and the majority of people got that correct. Because it went from the stage 3 to then having Slough and Eschar and stayed that way until discharge. So was this unstageable pressure ulcer due to Slough or Eschar present on admission? Would you say yes, no, or skip? Okay, just give it a moment. People are so appreciate how engaged everyone is, especially online. Okay, so let's see what the answer is. And in fact, it was no, right? It was unstageable when they first came in due to a non-removable dressing. And here we'd go through the scenario. This is actually how you would encode it. So 300B1 and B2 would be 0 and then skip. C1 and C2 would be 0 and then skip. Same thing with D1, the stage 4s would be 0 and skip. And then we get to 300E1 on admission. They had that non-removable dressing. And then it was at discharge. We didn't have any of those, right, because the dressing was removed. And then we skipped. And then number of unstageable pressure ulcers due to the wound bed having Slough and Eschar. We didn't have that at admission, but we do have it at discharge, so we code it as 1. And here's the rationale for that. So I just went through that, so you can read those questions. And again, this further explanation. And these are really good when you're doing training and education back at your facilities. Take some of these scenarios or take your own real scenarios that actually brings great value and do some coding scenarios. The more practice that you do, the better accuracy you're going to have. So let's look at another practice scenario. So here we have a patient admitted to the IRF with a stage 3 pressure ulcer under coccyx. On day 5 of the IRF stay, the ulcer is assessed as a stage 4 pressure ulcer. She is seen at the wound clinic and returned to the IRF with a dressing and ordered that the dressing is to remain intact until the next clinic visit. The patient is discharged to a skilled nursing facility prior to the follow-up to the wound clinic. At the time of discharge, this ulcer is covered with a non-removable dressing. Everyone got that scenario down? Okay. How would you code M0300 on the admission assessment? Would it be coded as 300C1 as a stage 3? 300D1 as a stage 4, 300E1 as unstageable due to a non-removable dressing or device, or 300F1 unstageable due to Slough or Eschar? And let's look at the answer. Most people have answered this already. Most people said a stage 3. And in fact, that is correct. That on admission, we had a stage 3 pressure ulcer. So now let's look at the discharge assessment. So how would you code M0300 on the discharge assessment? Would it be 300C1 as a stage 3, 300D1 as a stage 4, 300E1 as unstageable due to a non-removable dressing or device, or 300F1 unstageable due to Slough or Eschar? Okay. We have the most people have answered this. Let's see what the answer is. And in fact, it's unstageable due to non-removable dressing. We had a fair amount of people that wanted to code this as a stage 4, even though it had declined from the stage 3 into a stage 4. Again, remember, at the point of discharge, you couldn't assess the wound because of the dressing. So was this unstageable pressure ulcer or injury due to non-removable dressing or device present upon admission? Yes or no, or skip. So let's see what the answer is here. In fact, no, it wasn't there. We have some people, though, that are struggling, and I'm not sure whether they're in the room or online. I think it might be, maybe they're not clinicians, but I think there's some opportunity to, it's like 7 to 10 people. So I think there's some opportunity for whoever those 7 to 10 people are that are getting this wrong to maybe spend some time in the IRF-PAI manual around this and going through some of these scenarios. Okay. And then the practice scenario here just is exactly how you're going to code it. On admission, the person had a stage 3 pressure ulcer, so we coded that as 1. And you, on discharge, we had a unstageable pressure ulcer injury due to non-removable dressing. We had 1 of those, and none of them were present upon admission, and that's how we would encode this. And then this goes through everything that we just talked about. So the difference between an evolution of a wound, it came in as a stage 3, it went to a stage 4, and then they go to the clinic and now they have that non-removable dressing. We have to code it as having that non-removable dressing. So let's talk a moment about this idea of healed pressure ulcers. So the terminology referring to healed versus unhealed ulcers or injuries refers to whether the ulcer or injury is closed versus open. So a stage 1 pressure injury, a deep tissue injury, and unstageable pressure ulcers, although covered with tissue, Eschar, or Slough, would not be considered healed. So really what we're looking for is epithelialization, okay, closing the wound. For those of you that have spent any time working with wounds, we know that even though the skin closes, it's hard to tell what's going on with the underlying tissue. The tensile strength is about 80%, even when it's completely filled in. It's not the same as what we were born with, right? So it will never be as strong in that particular area. We want to make sure we never reverse or backstage, which is that opportunity to teach about what you're seeing when someone comes in at an admission. If they have a wound, you want to make sure you understood what its deepest anatomical stage was. Because as it is in its healing process, it could continue, you could have an issue where it goes deeper because that tissue is still very fragile. So let's look at another coding scenario. So in this coding scenario, a patient's skin assessment on admission to the IRF reveals no pressure ulcers or injuries. On day 5, while conducting a skin assessment, a stage 2 pressure ulcer is identified on the right elbow. On discharge, the patient's skin assessment reveals a healed stage 2 pressure ulcer on the right elbow. So they came in with nothing, they developed a stage 2, and at discharge, they've healed the stage 2. So how are we going to answer this one? How would you code M0210 on the admission assessment? Does this patient have 1 or more unhealed pressure ulcers or injuries? Okay, so the majority of people responded, and let's see what the answer is. No, right? Because they came in with no pressure ulcers or injury. How would you code M0210 on the discharge assessment? Does this patient have 1 or more unhealed pressure ulcers or injuries? So this is a discharge. And we have most people weighing in. Interesting. Okay, so let's go through and let's see what the answer is for this particular question. And it would be no, but yet I had 50 or 60 people who were saying yes. So let me just clarify this. So on admission assessment, skin was intact, right? We all agree on that? Skin was intact. So we have no ulcers or injuries. 5 or 6 days, whatever it was, into the stay, they end up with a stage 2 pressure ulcer on the elbow. You continue to care, you identify it, you treat it, you clinically manage it, you heal it, meaning it's closed. So at discharge, you do your skin assessment again, there is nothing present. Now you know that they had this intervening issue, but again, if we got to remember, these are 2 points in time, at admission and then at discharge. So at admission, they had nothing, they developed something, you treated it, you healed it, and now at discharge, they have nothing. So in fact, even though you had that ulcer and you treated it and it's now closed or healed, in fact, it wouldn't show up on your IRF-PAI. So this is exactly what we said. They had no pressure ulcers on admission, and then they developed it, you treated it, but then on discharge they didn't have it. So in fact, you would say 0 for all of these. So let's look at another practice scenario. A patient is admitted to the IRF with a stage 1 pressure ulcer on the coccyx. The skin assessment on the tissue surrounding the injury on day 6 is consistent with a DTI, a deep tissue injury. This DTI remains intact at the time of discharge to home 3 days later. So they came in with a stage 1, and then on day 6, it looks like it's got a deep tissue injury, and then that deep tissue injury remains at discharge. So how would you code M0300 on the admission assessment? Would it be M0300A1 as a stage 1, 300B1 as a stage 2, 300F1 as unstageable due to Slough or Eschar, or 300G1 unstageable due to a deep tissue injury? And we have most people answering the question. Let's see what the answer was. And that is correct. On admission, we had that stage 1 on the coccyx. How would you code M0300 at discharge assessment for this particular patient? So would you code it as 300A1 as stage 1, 300B1 as stage 2, 300F1 as unstageable due to Slough or Eschar, or a 300G1 unstageable due to a deep tissue injury? And we have the majority of people responded, so let's see what the answer is. And most people got this correct. It progressed now that it was a deep tissue injury. So we had that's, we had the ulcer then progressed to the point that we had a deep tissue injury, and it stayed that way upon discharge. Was this unstageable pressure ulcer present upon admission? And so was it M300G2 as a 1, meaning yes, or was it no, 300G2? We have the most people weighing in. And let's see what the answer is. No, we didn't have that deep tissue injury, but we do now, so we would code that. And here's going through the coding scenario. You had a stage 1 pressure ulcer here on admission. Everything else is coded as a 0 or a skip. And then we get to the point of 300E is 0, E2 is a skip, and then 300F1 is 0, F2 is a skip. Then we get down to 300G1, which is the unstageable pressure ulcers. On admission, we didn't have any, so it's a 0. On discharge, we have 1. And then it's saying of that 1, deep tissue injuries, how many of those were present upon admission? We're saying 0. Okay, and then here's just the rationale. Admission, the patient had a stage 1 pressure injury or coccyx. The subsequent skin assessment determined this injury to be a deep tissue injury, which remains at discharge. All right, let's go through this next scenario here, or next little bit about medical devices. So when an ulcer or injury is caused due to the use of a medical device, assess the areas to determine if the pressure is the primary cause. And these ulcers or injuries generally conform to the pattern or shape of the device. You see something and it's like on the calf, and you're saying, how the heck did they get that? And you'll look at their splints, you might look at their wheelchair, whatever, and you can often just match it up to something in their environment that matches that directly. If the pressure ulcer is determined to be a primary cause, use the staging system to stage the ulcer or injury and code in section M of the IRF-PAI. Again, if the ulcer is determined to be related to pressure, then we code it here. If not, we're not going to code it here, because we can end up with things, especially around lower legs and whatnot, that could have other things going on. They could be having other type of ulcer. So we need to make sure that what we're talking about here is pressure ulcer. Again, an opportunity for education, making sure that your staff understand there needs to be pressure involved for it to be coded here as a pressure ulcer. If the ulcer injury is not due to pressure, do not code in section M. So let's look at a scenario here. So a patient is admitted to the IRF with a right ankle foot orthosis. to compensate for weakness and foot drop. On the initial skin assessment, the clinician notes a stage 2 pressure ulcer on the right calf that conforms with the shape of the AFO. The I can never say this word. Anyway, I do stumble over that word, sorry about that, is consulted, and the AFO is the brace guy, that's what I call him, or the gal. The ulcer heals before discharge and no other pressure ulcers or injuries are present. So let's look at that scenario. How would you code M0210 on the admission assessment? Does the patient have one or more unhealed pressure ulcers or injuries? So is it yes or no? So this is M0200 on the admission assessment. All right, the majority of people have responded, and it looks like most people said yes, so let's see what the answer is, yes. So because we answered yes here, we're going to continue on to M0300, current number of unhealed pressure ulcers or injuries at each stage. So let's go on to the next slide here. How would you code M0300 on the admission assessment? Let's look at the coding here. Would you code M0300A1 as a stage 1, M0300B1 as a stage 2, M0300E1 is unstageable, non-removable dressing or device, and or M0300G1 unstageable due to a deep tissue injury? We have most people who have responded, so let's go ahead and see the answer. And in fact, we would code M0300B1 as a stage 2, equaling a 1 from that device. So the next question is, how would you code M0210 on the discharge assessment? Does the patient have one or more unhealed pressure ulcers or injury? So how would you code M0210 on the discharge? Would you code it as A, or 0, no, or 1, yes? Does this patient have one or more unhealed pressure ulcers? And again, this is at discharge. All right, the majority of people have weighed in, and the answer is no, because medication interventions? Skip to N205005 to medication intervention. Because how would you code M0210 on the discharge assessment? Does the patient have one or more unhealed pressure ulcers or injuries? No. So now you're going to skip out of this because they don't have anything that you need to code. So here, would you look at the coding? You have unhealed pressure ulcers on the admission assessment for M0210. You have, yes, we have 1. And then the number of the stage 2 pressure ulcers at M0301B on admission is 1. And then the number of the stage 2 pressure ulcers that were present upon admission is a skip. And so on discharge, we don't have any, right? It's a 0, skip, skip. So really what would happen here, if you're doing this on a computer, just skip you right out of this section. Once you say you don't have any at discharge, it's going to skip you right out of the section. So you don't have to even deal with these issues. So the rationale here is the area that was identified on the calf beneath the AFO was determined to be caused by the pressure of the device against the skin surface. So first and foremost, they investigated and realized that the splint probably matched right up, put the splint on, it matched right up to the wound. It usually is a similar shape. They determined that this wound was pressure related and the medical device, and it resulted from that use. And so the fact that it had pressure, it generally conforms with the pattern and shape of the device, and the injury should be staged using the staging system. So this is, again, an important, I think, teaching point for your staff. You're following the instructions for the purpose of coding. Determination was made that the lesion being assessed is primarily related to pressure, and that other conditions, skin tears, tape burns, moisture-associated skin damage, or excoriation have been ruled out. So we're taking all of those things out of it, and we said what we think we're seeing here is pressure as the primary cause. And because of that, we'll code it here. Again, great opportunity for education of your staff. So let's talk, let me go through this next. So the number of stage 2 pressure ulcers coded as 1 on the admission assessment, and then the stage 2 pressure ulcer is healed at the time of discharge, and there are no other pressure ulcers or injury. Therefore, M0210 unhealed pressure ulcers or injuries is coded as a 0, and the item would be skipped. So let's spend a moment talking about mucosal ulcers. So those are a little different, right? So mucosal pressure ulcers are not staged using our skin pressure ulcer/injury staging system because anatomical tissue comparisons cannot be made. Therefore, mucosal ulcers, for example, those related to NG tubes, oxygen tubing, endotracheal tubes, urinary catheter, mucosal ulcers in the oral cavity should not be coded on the IRF-PAI as pressure related. An important point, an opportunity for education. So make sure that your staff understand that, anyone who will be coding that ulcer. It's amazing how many people want to go ahead and they say, well, it's an ulcer. And people do this for stasis ulcers. They do all kinds, you get a nice round stasis ulcer on the leg, and you'll go around and people want to say, well, it's open, they want to stage it. And the one thing the caveat we need to say to our staff is, yes, you clinically want to treat it, you might want to measure it, you want to describe it, but you're not staging it as a pressure ulcer. The staging has to have primary pressure related to it. And I know I'm beating a dead horse, but I can't even tell you how many times when we go out and you educate on this, they're like, all of a sudden someone will go, oh, it needs to have pressure. Yes. Very good. That's one of the key things. So just an opportunity, ongoing. You get used to doing certain things and people get into a pattern. And I've seen nurses arguing on the floor and they're like, well, it's open, it's stage 3, and they're describing the whole thing, but it is, a peripheral vascular ulcer versus anything related to pressure. So there's other kinds of ulcers. Here we have the Kennedy ulcers. So a Kennedy ulcer is a skin ulcer that occurs at the end of life, and they traditionally called the Kennedy or terminal ulcers. And although we'll identify them and we may treat them, we're not going to encode it on section M. So again, another opportunity for education with your staff. So the evolution and appearance differ from a typical pressure ulcer or injury. It's related to tissue perfusion issues due to organ and skin failure, right? Our skin being one of our largest organs. So as someone's in the dying process, these get to be an issue. You will see them, and people will traditionally want to code them in section M. So if you're going to do some education, I would maybe describe a particular patient in your environment who had a Kennedy ulcer, and then describe it, measure it. If you have a picture, it would be great for your teaching of your staff, and say, how would you code this, or would you code this on the IRF-PAI? So a great opportunity here. We're going to go into the summary, but I just want to take a moment to just kind of highlight a couple of common themes that I had an opportunity in prep for today's session to read through all the Q&As that have been coming in. There's a couple of themes that I just wanted to talk about. One of the themes that came out, and I can't even tell you any number of questions around it, is what happens when we do the initial skin assessment? Like, do we have 3 days to do that initial skin assessment? What happens if I do the initial skin assessment and we do head to toe and we don't identify anything, then the next morning we have a blister on the heel? How do I code that? That's the question. How do we code that? Well, in fact, what we're trying to do and understand, even though you have an assessment time frame, and this comes up in home care also, I was teaching home care, they have 5 days to get their OASIS done. It is around as close to admission as possible, right? Clinically, we know we want to get in there. We want to take a look at our patients. We want to do a head-to-toe assessment. And that initial skin assessment, whatever you find on that initial skin assessment is, guess what? Your admission initial skin assessment. And anything that changes from that, remember these are points in time, anything that changes from that, acknowledge it, treat it, whatever, and then you're going to look at it at another point in time, and that's at discharge. People want to go back and say, but really, we probably, it happened within our assessment time frame, and I don't want to get dinged, so I should really code this. So this is about clinically, what we're trying to do here is have a cross-cutting measure, right, that is used in all of the post-acute settings. And the same thing, we want to do that initial skin assessment as close to the time that the patient arrives, and we want to document what we see. Now, the one caveat I probably will give you on that is that scenario I gave you a little bit earlier, where someone does a really wonderful job describing the wound, and then it's obviously through the descriptions clearly a stage 3, and they write stage 2. So you take they may not be even encoding it on the IRF-PAI at that point, right? But they probably in their documentation. You probably want to take that nurse aside and say, let's have an opportunity, just-in-time education here. Let's talk about what you see. I know it was shallow. I know it didn't seem like a deep wound or whatever, but if you see this yellow, the slough, that is, once we have that, the tissue damage is such that it is a stage 3. All right, and if you couldn't see the wound bed at all, then it would probably just be coded as unstageable due to Slough and Eschar. So take the opportunity to audit some of your charts. Some of the examples and questions that came out is the nurse assessed this as the wounds, having no wounds, and then the skin is intact. And then 24 hours later, 48 hours later, the skin team comes around, or the skin nurse comes around and finds an ulcer. On one hand, I'm wondering, why is the skin team looking at that person? Someone's identified something, but I don't know. And then again, the same scenario. You have to then go by what was seen on that initial skin assessment. An important point of that. And then the other thing are lots of questions around this idea of people still trying to wrap their head around something being new or worsened if it deteriorates with a Slough or Eschar, especially around the stage 4. So that scenario we talked about, that stage 4 pressure ulcer that all of a sudden had Slough and Eschar on it. And so the question is, well, wait a minute, it's a stage 4. We know it's a stage 4. It can't get any worse than that. But for the coding on the IRF-PAI and consistent across all the PAC settings, it would be considered worsened with the Slough and the Eschar. The science is still evolving on that, so I put that out there. All right, so in summary, changes in skin integrity post-acute care. The pressure ulcer injury is a cross-setting quality measure, which we just talked about. The data collection for this measure began on October 1st, 2018, and we still get questions into the help desk around some of the things that we talked about. There's still some opportunities just in the polling that we saw, that there are some people who are not grasping the subtleties. This is not the hardest thing in the world, but it's certainly not the easiest section in the world either. So opportunities for education and training. When you take out your action plans, what is it? If I asked you to go back, if I said to you, and I just put it to any person in the audience, how confident are you that your staff, nursing staff primarily, could assess and document a wound? And how confident are you? Would you bet your house on it, or $100 on it? or a lunch ticket or something on that. It's amazing how many people are like, well, and I'm like, okay, great opportunity. How do you orient people who are new to your organization? How do you make sure they're competent? And how do you do ongoing competency and assessment? Case-based learning is a wonderful way to do it. So just taking the opportunity for that. The measure replaces the percent of residents or patients with pressure ulcers that are new or worsened. So this has been around for a while now. I think most of you are pretty confident and comfortable with this. So for this measure, the ulcer injury is considered new or worsened at discharge if the discharge assessment shows, as we talked about, stage 2 through 4, or unstageable pressure ulcers or injury that were not present on admission at that stage. That's the statement. And again, 2 points in time. So we're finished up a couple of minutes early on this, but I think what I'd like people to do is take a couple of minutes. I see Bridget's probably going to come up and give us some comments, but what I'd like people to do, both whether you're watching this live streaming and or you're in the room today, take out your action plans. I don't know how many people pulled it out. It is amazing, though, once you've gone through 2 days of training like this, if you jot these ideas and these thoughts down, when you go back to your facilities, you have a plan that then you can say, let me deploy this plan. How confident are we? You go back to your team. How confident are we at our organization that people get all these subtleties that we just talked about? And if you're not confident, put in an education plan in place. Put in some sort of competencies. Put in some sort of training, whether it's related to this or medication. Again, there's subtleties within each one of these measures. You know, how confident are you around mucosal, the people wanting to code something in a mucosal area as a pressure ulcer, or something around a peripheral vascular as pressure ulcer when there's non-primary ulcers? How confident are you with moisture-associated skin injury and pressure both together? Would someone be able to encode that? If you're not confident, this is an opportunity. These slides will all be presented and posted with the actual answers, so you can use them so that you have the answers for all of these scenarios, and it will be available for you to use in your training. And then I think it's very, very powerful if you take a case study that your staff can relate to. You know, Mrs. Jones, do you remember her? She was in 300, you know, room 300, bed A, and she had blah, 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 and everyone's like, oh, yeah, I remember. Let's talk about her case and how we would code that and go through that. Because then your staff's like, it's not esoteric, it's not just out there, these are your cases. Take your most difficult cases and use those as training cases. Thank you very much, and I'm going to turn over to Bridget.